For right bundle branch blocks, the RSR pattern in V1 through V3 is going to give you that classic M-shaped QRS. It'll be wide, and you'll have a slurred S wave as well. So this is just kind of a reverse pattern, as you can see. In V1 with a right bundle, you'll have an M pattern, whereas V6 now you'll have a W pattern. So then we'll look at R wave progression, and we'll look at this transition between V3 and V4. So early progression generally alludes to three possible causes: either a right bundle branch block, right ventricular hypertrophy, or possible posterior MI, as you can see here in this example. If we have, for example, late R wave progression, whereas our previous example was early progression, this could also indicate three potential causes: left ventricular hypertrophy, left bundle branch block, and a possible anterior MI with late R wave progression, as you can see in the example here. So let's take a quick look at the coronary artery anatomy. I think it's important to know at least the larger coronary arteries, because this will help you identify the territory that's being affected, especially when you're dealing with an MI. So you can see this example here, and hit pause if you need to reevaluate and study up on this. So next we'll look at STEMI. So in order to call a STEMI, the general consensus is that you have to have greater than or equal to 2 millimeters of ST segment elevation and 2 contiguous precordial leads. So that's 2 contiguous precordial leads of 2 millimeters, equal to 2 millimeters or greater. In any other leads other than precordial leads, greater than 1 millimeter in 2 contiguous leads. And then there's 2 other categories that are considered to be a STEMI, even though there might not be true ST elevations. This is a new left bundle branch block and a posterior MI. So here's a little screen capture for you for identifying where potential MIs are and what they're affected, or what they're affecting. Here's a couple examples. Now let's talk about ST depression. So in order to call a STEMI, you also have to have reciprocal changes. So ST depression can be either upsloping, downsloping, or horizontal. Now, horizontal or downsloping ST depression, usually greater than or equal to 0.5 millimeters at the J point, in greater than 2 contiguous leads, indicates myocardial ischemia. So you could have horizontal or downsloping ST depression that meets the criteria deep enough, 0.5 millimeters at the J point, in 2 contiguous leads, and you can correlate this clinically with their presentation and say that this is likely some ischemia that they're experiencing, even though you may not have ST elevation immediately demonstrating on the EKG. ST depression greater than 1 millimeter is more specific and conveys a worse prognosis usually. ST depression greater than 2 millimeters in 3 or more contiguous leads is also associated with a high probability of end-STEMI and predicts significant mortality. Upsloping ST depression is somewhat non-specific for any myocardial ischemia. One really important next step is to evaluate for any T-wave inversion. So for T-wave inversion, this has to be generally at least 1 millimeter deep. It has to be present in greater than 2 continuous leads that have dominant R waves. So that's important to note. These can be dynamic, so they may not be present on an old EKG, or if you get consecutive EKGs at different time intervals, you could observe this changing over time. One really important category of T-wave inversion I would suggest knowing and just committing to memory is something called Whelan's syndrome, which is a pattern of inverted or biphasic T waves in V2, V3, and V4. This correlates clinically, of course, with your patient who's having what sounds to be ischemic chest pain. This is highly specific for critical stenosis of the LAD. And here's an image of that. This is Whelan's. You can note the deep T-wave inversion in V2, V3, and the biphasic deep T-wave inversion in V2, V3. So next, let's talk about tachycardia. So in order to evaluate tachycardia, we need to quickly determine, is this a narrow QRS complex or is this a wide QRS complex? So is this a narrow complex or wide complex tachycardia? Is it regular or irregular? Now, a regular narrow complex tachycardia could potentially be sinus tachycardia, atrial tachycardia, atrial flutter, SVT, or AVNRT. Now, if it's irregular narrow complex tachycardia, this could be atrial fibrillation, atrial flutter with variable block, or MAT, for example. Now, if this is a regular wide complex tachycardia, this could be VT, V flutter, tachycardia with aberrancy, or potentially hyperkalemia. Now, if we run into an irregular wide complex tachycardia, this is generally the bad one that you don't want to see, but this could either be torsade or VFib, for example. I usually recommend with students creating a branching algorithm approach. It's helpful to write it out with the various types of tachycardia. So again, is it narrow versus wide? Is it regular versus irregular? And those are your big branch points. And here's some different examples here. So now we'll look at bradycardia. Again, is this narrow or wide complex? Is it regular or irregular bradycardia? Now, for example, regular narrow complex bradycardia, this could just be sinus. It could be junctional. It could be complete AV block, or also called a junctional escape rhythm. It could also be atrial flutter with a high degree block. Irregular narrow complex bradycardia, this could be, again, sinus. Atrial fibrillation with slow ventricular response. Atrial flutter with variable block. Type 1 and type 2 second degree blocks. Now, if this is regular wide complex bradycardia, this could be an idioventricular rhythm, a complete AV block with a ventricular escape, regular bradycardia with aberrancy, or a bundle branch block. Now, if it's an irregular wide complex bradycardia, this could be a type 1 or type 2 second degree block, irregular bradycardia with a bundle branch block. Usually you don't see a lot of irregular wide complex bradycardias, but again, I usually instruct students to simply write out the algorithm branch point to help clue in on your differentials. And I think if you practice these over time, you'll learn to identify which diagnoses are associated with each branch point. So lastly, I think it's important as an EM provider to quickly be able to identify hyperkalemia on an ECG. I think out of all the electrolyte abnormalities that may show up on an EKG, this is the most important to be able to identify right just visually right off the bat. So hyperkalemia, generally we say greater than 5.5 milliequivalents per liter is associated with repolarization abnormalities. So I'm sure everyone remembers you start to see the peaked T waves. Now again, this isn't necessarily correlating to what the actual potassium level is, the serum potassium level is. You can see this develop quickly. Sometimes it develops late and maybe not quite as high of a potassium as you may think. So here's an example here of a peaked T wave. So generally we say, well, imagine tying a string to that T wave and then just slightly pulling that string up all the way up until it really gets peaked, and oftentimes is above the QRS amplitude. So as hyperkalemia progresses, and it's common to see these in your dialysis patients who, for whatever reason, haven't made it to dialysis for a couple of days, it's important to identify the progression of hyperkalemia. So, for example, greater than 6.5 milliequivalents per liter is generally associated with progressive paralysis of the atria. Now this is kind of just a rough serum potassium level, so it may or may not be exactly 6.5, but the P wave starts to widen and starts to become flattened. The PR segment lengthens, and then as it progresses, the P waves eventually disappear. And here's an example of that. Now, as the hyperkalemia worsens, let's say 7.0 milliequivalents per liter, this is generally associated with conduction abnormalities and bradycardia. So you'll have a prolonged QRS interval with a weird, they say a bizarre QRS morphology. You can develop high-grade AV blocks with slow junctional and ventricular escape rhythms, any kind of conduction block, a bundle branch block, vesicular block, sinus bradycardia, or you can even develop slow atrial fibrillation until you get the development of a sine wave, which is considered a pre-terminal rhythm. So that sine wave is something very, very important that you need to just look at and be able to identify in the right clinical context. These patients are usually really sick looking or really chronically ill. looking. And so a sine wave, again, is a pre-terminal rhythm. They won't last very long in this sine wave rhythm before progressing. And then lastly, we generally say the cutoff is 9.0 milliequivalents per liter. Generally causes cardiac arrest. You can get an asystolic arrest, VFib arrest, or you can also have a PEA arrest with a bizarre wide complex rhythm. So it's really important, again, to be able to quickly pick up and identify what hyperkalemia looks like on an ECG. I think that's a very important one as an emergency medicine provider to know. And with that, we will call this our first EKG lecture. So thanks for listening.